I've started the recording, but I'm going to give us just about another couple minutes to see if anyone else is going to join. And then I will give an introduction and we can get started.
Excellent.
All right, I'll have us get started. This is being recorded, so this will be available on our website for people to come back to and refer to later. So we would like to welcome everyone to the MTAAP Subspecialist webinar for March. Today we welcome Patrick Parenzin, and I apologize if I butchered your last name there, from Seattle Children's, who will be presenting on towing, bowing, and flat feet in children. I'll turn it over to you.
I'm Patrick Parenzin, very close. Physician assistant with Seattle Children's and Department of Orthopedics. I have clinics in Missoula, Kalispell, and Bozeman, and then run around and talk about this stuff. So towing, bowing, and flat feet in kids. So large variation in how kids are shaped. Let's talk about it. All right, quick pre-test. What's the most common cause of in-towing in children? Pick your best answer. What is the best way to evaluate in-towing or out-towing? Rotational profile, MRI, X-ray, or hip exam. What causes W sitting? Does it cause osteoarthritis? A, B, C, or D? And what treatment is required for a flexible flat foot? AFOs, inserts, custom inserts, or no treatment? So the goal today is to understand what's normal and then how normal progresses. We're going to learn how to assess lower extremity alignment and distinguish physiologic versus pathologic. And to answer this young man's burning question, am I pathologic? These are pictures of my children, by the way. Towing and bowing terminology. Normal equals a wide range. So is it functional? That's our biggest concern on the pediatric orthopedic side. Version is technically a normal twist. Torsion is beyond 2 standard deviations. We often use them interchangeably. There can be lots of causes and rule outs for toes pointing in or out and bowed legs or knocked knees. Comes from different places. Things like hip dysplasia, clubfoot, neuromuscular disease, all can play a part. We're going to talk mostly about what is normal. So when you assess them, you're localizing the deformity. These are common concerns that will walk into your office: in-towing, out-towing, bowed legs, knocked knees, and flat feet. I'm sure you've all seen this. Your job, where's the source? We're going to teach you how to do that. So for in-towing, part of your history is who's worried about it. Is there family history? Is there pain? How long has it been going on? Is it worse? Basic questions in a history. We always start with a gait analysis. Here's Lauren Wilson taking a look at this child walk. We always look for a limp. Is there asymmetry? Do they walk up on their toes? We always make them run, and particularly for our CP kids, it increases tone, which you may not see when they're just walking. Keep in mind when they walk, there's a wide range of normal with regards to toes pointing in and pointing out. While they're still standing, I always have them look at the front and the back. This child is about 3. Notice he has a beautifully collapsed arch, which is normal in a child under 6. When he goes up on his toes, his arch is accentuated, and his heel, you can see his heel from behind there, drops into varus. That's exactly what you want to see. When they're non-weight bearing, you should have a nice little arch, and then the Achilles should be flexible. This is with knee straight and knee bent. It's a test called the Silver-Schultz test. Just test flexibility of gastroc and soleus. Now, this is a standard flat foot. This is normal, normal, normal. They're not going to get an arch until they're around 6 years of age anyway, if they're going to get an arch, and 25 to 50% of us don't have an arch. This whole family, those 3 little boys share my genetics, and they all have pancake flat feet that are flexible because they get them from their mom, who's on the left. I put them up on the table and look at the bottom of the foot. This child has a curved lateral border. All right, so we draw a lateral foot line, push over the first MTP, and draw a imaginary heel bisector line. Normal is through the second and third ray. This is a good example of metatarsus adductus, which can be one of the causes of end-toeing. Most of these improve by the time they're 12 months, but if they're stiff, they're going to require casting. There's some debate whether or not there's some association with DDH, but you're going to check their hips no matter what. Most are going to be flexible. Wandering toe, this is a very dynamic deformity. It goes away as soon as they sit down. So this can be pretty dramatic, but it is all dynamic and goes away. We put them over on their belly and prone, looking down at the bottom of the feet. And so you'll see in figure B, the foot is pointing out, so the tibia is rotated out. Well, in this instance, this baby, the tibia is rotated in, which is typical in an infant, small child. The tibia is rotated in. This is the most common cause of end-toeing. Oftentimes the left is worse than the right. This is a 1 to 3 year olds, and if it doesn't go away, there's some studies that have shown that sprinters, midfielders, anyone in the sprinting sports, when they walk, their toes point in, and it's coming from their tibia. While they're still on their belly, we let their legs fall out to the side. It's easily done prone. Large variation. It's most common in the girls 2 to 5. They have the kissing patellae, and they sit in a W position. It usually gets better with growth, but it can persist. And there's no association with osteoarthritis. Very, very common. And we wait till they're about 10, 11 years of age. This usually goes away to them mostly. So you can determine the source, whether it's the foot, the tibia, or the femur. As a child grows, the bones rotate out, so they unwind from birth. So here's a little 4-year-old girl. She's healthy. She loves soccer. Her family wants new inserts. She's had inserts in her shoes for a long time because she had flat feet and end-toeing. She sits in a W, which the parents have been told is bad, and they constantly cue her to stop. So let's watch her walk. As you can see, her feet are pointing in. We're going to look at her feet. This is her standing, goes up on her toes. She has a nice arch. Heel drops in. She has regular old pes planus, flexible, flat feet. Normal. When she's on her belly, we draw an imaginary line down her thigh and down her foot. It's a thigh-foot angle. Her tibia is rotated in on both sides. So she has internal tibial torsion. Very, very common. While she's on her belly, internally rotate the hip. She can almost touch the plinth. She has femoral torsion. She sits in a W because that's the shape of her femur. What she got? She's got end-toeing due to physiologic internal tibial torsion and internal femoral torsion, and asymptomatic flexible flat feet. She is a normal kiddo. We just coach the parents that usually by 10, a lot of this is going to go away. She may retain the flexible flat feet, but as long as they're painless and flexible, they are normal. Get wider shoes. I always point families to this handout at global-help.org. You type in the search bar what parents should know, and you'll get the PDF version of this in multiple languages. Talk about out-toeing. So to evaluate out-toeing, you always complete a rotational profile, localize the site. Asymmetric hip rotation always requires further evaluation. This is because of the skiffies out there that may float through. And it is normal for there to be external tibial version. If it's just coming from the tibia, not concerned. If it's coming from the femur, take an x-ray of the pelvis to rule out a skiffy. And most of us have symmetric mild outtowing. Let's talk about knock knees and bowed legs. So the normal infant is bow-legged, sometimes one side more than the other. We then are our peak age of knock knees around 3 to 4, and by 7 to 10, we have our adult profile, whatever that is. So tibial bowing, it's usually in the first year, originates from the middle and distal tibia. You can see this little guy, he's got these chunky rolls along the medial border of his tibia. It's very normal. You just follow them with serial exams, make sure that transcondylar distance, the distance between their knees, is not greater than 7 to 10 centimeters. Blount's disease, right? This is from the knee, vitamin D deficiency rickets. See the difference? This is quite significant. And the measurement between the knees is going to be significant as well, usually well over 10 centimeters. There's a 12-year-old with bowed legs. He's got knee pain. He's always had bowed legs. He's had increasing pain over the last 2 years with walking. So I don't have a tape measure up, but the distance between his knees is significant. We can get just a video here, watch him walk. Wide basically, he's almost walking on the outside of his feet. It's very painful. These are his x-rays. Oops. See, he's got fairly significant Blount's. So he's got a growth plate that's just not wanting to work right, crumpling on the inside. So knock knees, the other end of the spectrum. This is at its max between 3 and 4 years old. And the distance between the ankles, if it gets over 10 centimeters, always make a referral. So a normal chunky toddler with a normal intermalleolar distance of about 3 centimeters here. You always want to measure this with the patella forward. Gyn is the questions you can always ask yourself: is the child healthy, normal height? Are they able to function, and do they have pain? You have this long list of things like skeletal dysplasias that can cause gynovalgum or gynovarum. All right, this kiddo is 3. He has knock knees. Just immigrated from the Congo. He runs and plays. He has no pain. 40th percentile for height, but one side slightly more than the other, and he has this possible remote injury at 2. So his intermalleolar distance is well in double digits. And you can see that his right side is angulated more than the left. So what's going on here is that he probably had a tibial fracture. He overgrew medially. This will correct itself, believe it or not. So the vast majority of rotational deformities are normal, usually are benign and resolve with time. You can usually, with your history and exam, rule out pathologic causes. As long as there's no pain in the limb, oftentimes it's normal. And then always evaluate asymmetric hip rotation, particularly the loss of internal rotation, because we don't want to miss a skiffy, slip capital femoral epiphysis. Anyone will benefit from a referral if you can't convince them they're normal. Anyone that's over 7 with persistent intowing or outtowing, and then a stiff metatarsus adductus, usually want to consider a referral at 6 months of age, and any asymmetry of hip rotation, and bowing if it's below the 5th percentile or over 2 to 3 years of age with true gynovarum. So let's answer this kiddo's question. This is your newborn. Got a fair amount of bowing. This is him at 1 year. Still has some bowing. Toes are pointing in. This is him at 3. He's got knocked knees. And then this is him at 10. He's back to being bow-legged. That is a normal progression in a normal kiddo. So I say, what's the most common cause of in-toeing in children? It is, you are correct, internal tibial torsion. What's the best way to evaluate in-toeing or out-toeing? It is with the rotational profile. And what causes W sitting and does it cause osteoarthritis? The answer is femoral anaversion and no. And what treatment is required for a flexible flat foot? Remember, flexible, pain-free, no treatment. Call me anytime or email. Anyone have any questions?
I had a quick question. For that, I think he was the 12-year-old. My video on here. For the 12-year-old that had the varus deformity that was walking.
Yeah.
What do you do with that kid? Does he need surgery or yeah, what is the next step for him?
Surgery.
Okay.
He needs osteotomies to straighten that out. I mean, I'll get back down to that picture. It's a great question. This kiddo?
Yeah.
Yeah, so, oh, shoot. Let me go backwards. Yeah, so he's going to get osteotomies over the proximal tibia. So the thing called the cora, center of rotational angle, right here. Basically, they do a opening wedge osteotomy and push things up most of the time. No, there's you can stop the growth of this side, but this is a sick physis, so it's not going to correct like a typical growth plate surgery. So they have to stuff some bone in there and correct his deformity.
Gotcha. Okay.
Yeah.
Thanks.
Yeah, you bet.
Hey, Patrick. I
I'm
have no
Dr.
voice,
Wilson.
but how are you?
I'm good.
I have a question about Skippy. You said, Skippy as a cause of in-toeing, kind of evaluating asymmetry in the hips. How often is that painless? I feel like the ones I see in the hospital, usually they're, like a painful sort of situation.
Yeah, oftentimes it's a chronic skiffy, and they've had it for sometimes well over a year. So acute on chronic. They're playing basketball and it's out toeing. So the first thing you're going to see is usually one side's going to be out toed. It's usually unilateral, but it can be bilateral. I just had a kiddo the other day that was a sibling of one of my patients, and she complained of hip pain for over a year, and she just was running funny, and they finally took an x-ray and she had bilateral skiffies, but they were chronic at that point, acute on chronic, and she just needed 2 screws to hold them there. But yeah, anytime a child is significantly out-toed and it's asymmetric, you got to work that out. Just take a picture of the pelvis. But that's where the rotational profile should be able to guide you. So I mean, it's so easy just to throw them on their belly and let the legs fall out to the side. Well, if the legs don't fall out to the side the same, let me show you that picture. I should put in something about Skiffy into this lecture, but yeah, so when they're on their belly and their legs are out to the side, like this little girl, you can imagine if one side is up and the other side goes all the way down, something's getting in the way. And that's when that head of the femur slides down, it melts off to the side and it blocks rotation. And so they end up with this obligate external rotation. So their foot sticks out and they'll run down the basketball court with their foot sticking out. It's quite shocking. But that's also why as part of the eval, I always make a kid run, because it will, if it hurts, it cranks up the pain when they run. I mean, that's the skiffies, they'll start to limp. Not only will they walk with an out-toed gait, but they'll limp, particularly on the side that's painful. It's a good
That makes
question.
sense. Sorry, I was listening. I meant to say out-toeing, but
I know what you meant.
in, out, whatever. Are there other hip things that we need to be thinking about other than Skiffy if you have that asymmetry there? like DDH does that a little bit too, right?
It can. The scary part
Yeah.
about DDH, and that kind of goes beyond this lecture, but DDH in and of itself, particularly if it's bilateral, they'll have the same amount of abduction, but it's usually limited abduction and flexion. So they're either, if they're Galeazzi negative, so if you put them on their back and their knees are the same height, and then you go to abduct them one side, if it's dislocated, if they're both dislocated, they're gonna actually, let me turn on my video. So I'm pantomiming to no one here. So if you get their knees up and they're Galeazzi negative, and then you just go to abduct, if it's bilateral, they're gonna be symmetric, right? So if they're Galeazzi positive and this is your side that's out, when you drop it, it won't go that far. This side will go out that way. So any asymmetry, always take a picture. It's cheap, it's easy. Just take an x-ray. If there's even a hint of asymmetry, take a picture. But that's the catch. If it's bilateral dysplasia, hip dysplasia, it's sometimes really difficult to pick up. Their butt will stick out more. I mean, there's a few other physical exam findings, but the asymmetry is only going to pop up in a unilateral, which aren't all of them, but are some of them. But that won't be really an internal external rotation. That'll be abduction. Yeah. Any other questions? This is a great resource. So at global-help.org, you can grab these and print them out, the pamphlets. They're really helpful. Dr. Staley, this was his project, and he has all kinds of lectures on here. Super helpful.
Well, I think we had a kid with kind of a rigid metatarsus adductus that we said that needed to see you last week. So hopefully they're scheduling
yeah.
with you soon.
How
But
old are they?
was a newborn last week who went home who had septooptic dysplasia as well. And so it was maybe not their highest priority on their list, but
Yeah.
it was something we told them needed to happen. So, yeah.
Yeah, and that's, those are, you just grab the heel and push on it, and if it doesn't want to push, we got to think about casting it. We'll give them a couple months just to see what happens, but
Okay.
oftentimes if it's stiff, you got to push it over,
Cool.
which is
Yeah,
fun. It's fun to do clinically. Be honest.
Cool. Awesome. Yeah, we sent them to Charlie Hastings. I think the nurse practitioner saw them because Charlie's taking his first vacation in forever.
Oh,
So
good for him. That's great.
awesome.
I just burned through all that's usually about a 45-minute lecture, but when I don't have feedback and I'm not staring at people, it would appear I go really fast.
That's okay. It was good. It was very efficient. Thank
Anyone
you.
with any other questions? No?
Great. We
Okay.
post this in the password protected members page on AAP, so you can refer people to your talk if they want to hear it. So thanks.
Well, thank you guys.
Yeah, thank you
Thanks.
so much.
You bet. Anytime.
Thanks for joining us, and we'll have another one next month.
All right. You guys take care.
Bye.
Bye-bye.